The following podcast is part of a certified educational activity titled Prioritizing Patient-Centric Care in Biliary Tract Cancer, Leveraging Immunotherapy Platforms to Overcome Challenges in the Advanced Setting. Access the entire activity and complete the post-test at peerview.com/EUX860. Downloadable slides and practice aids are also available.
Hello and welcome to this TVU educational program, which is entitled Prioritizing Patient-Centric Care in Biliary Tract Cancer. My name is Angela Mamarca and I am a medical oncologist specialized in GI malignancies with a special interest in biliary tract cancer at Fundación Jiménez Díaz University Hospital in Madrid, Spain. During today's program, we will be using a case-based format to illustrate the real-world applications for best practices to leverage immunotherapy platforms to overcome challenges for biliary tract cancer in the advanced setting. So let's begin with our educational goals for today. Our goals for today are to improve the understanding of the latest clinical data supporting immune-based strategies in the upfront management of advanced biliary tract cancer. We will also enhance our skills to build personalized treatment plans based on the latest evidence, guideline recommendations, and patient-specific factors in advanced biliary tract cancer. Thirdly, we will provide everyone with tools to develop team-based strategies to address the intricacies of care delivery in biliary tract cancer, including care coordination, patient engagement, and immune-mediated adverse event management. First, we are going to speak on how to address the unmet need in biliary tract cancer and where does immunotherapy fit in within all the challenges that we face in our clinical practice. And in order to do that, I'm going to introduce you our first patient. His name is Philip, a 67-year-old male who has been newly diagnosed with malignancy. He presented with history of abdominal pain, nausea, and itchy skin. In the initial workup, we have tumor markers C91 of 20, albumin of 4, total bilirubin normal 0.5. We have a CT scan that showed multiple liver lesions, with the largest measuring up to 7 centimeters located in the right hepatic lobe, and also multiple enlarged aortic lymph nodes. There was an ultrasound-guided liver mass biopsy that confirmed a poorly differentiated adenocarcinoma. We are going to come back to Philip's case, but we would first like to review biliary tract malignancies. Biliary tract cancer includes cholangiocarcinoma and so-called bladder cancer. As we can see in this picture, cholangiocarcinoma can be further divided in intrahepatic, perihilar, and distal cholangiocarcinoma. Very important to take into account the anatomical considerations because they will have a clinical impact and also more and more we know molecular implications as well. Why are biliary tract cancer becoming so relevant? Well, the truth is that these tumors are becoming more and more frequent, and as we can see in the second graph, the diagnosis of cholangiocarcinoma is increasing every year. And the problem we are facing is that prognosis is still very poor, and that we are really facing very dismal outcomes for our patients. Very fortunately, a lot of research has been ongoing in the latest years, and the management of biliary tract cancer is really changing every year. This is the summary of the latest guidelines from ESMO that were last updated and published in 2023 for biliary tract tumors. As we see, for early stage, the primary aim of treatment is going to be curative surgery followed by adjuvant capecitabine. Unfortunately, very few patients are diagnosed at early stage, and majority of patients will be diagnosed with locally advanced or advanced metastatic disease, where the first-line treatment option is currently the combination of cisplatin and gemcitabine with durvalumab or pembrolizumab as immunotherapy compounds that we can combine with this chemotherapy approach. Also very important is to perform molecular profiling because in the second-line setting, in the absence of a targetable alteration, we will have chemotherapy as a treatment option with FOLFOX and also 5-FU and monoliposomal irinotecan. But as we can see, there is a variety of molecular alterations for which we have targeted therapies available. Therefore, very important to perform the molecular profiling so we can plan ahead in order to achieve this precision medicine approach in biliary tract tumors. The truth and one of the challenges, as I mentioned previously, is that not every patient will reach these second and third line treatment options. And unfortunately, majority of the patients will only receive the first line of treatment and will become too poor to get a second or a third line treatment option, which is one of our main challenges currently. molecular profiling is very important because more and more we have different alterations that we can target. It's also important to take into account whether we are treating a patient with a gallbladder cancer, an intrahepatic or an extrahepatic cholangiocarcinoma, because they are not going to only have different clinical pictures and different clinical complications, but also different molecular alterations that we could target. And as we can see here, we have more of a predominance of, for example, EGFR2 fusions and IDH1 mutations for patients with intrahepatic cholangiocarcinoma. And in contrast, we have more of an HER2 amplification for patients with gallbladder or extrahepatic cholangiocarcinoma. So speaking about immunotherapy markers, this is quite challenging for cholangiocarcinoma and gallbladder cancer. The truth is that the mutation load that we see in these tumors is kind of medium, is not very, very high. And this makes immunotherapy on its own challenging to deliver in biliary tract tumors. And the main reason why it has been combined with chemotherapy options is platinum immunotherapy in the first-line setting. Let's go back to Philip, our 67-year-old patient who was newly diagnosed with, as we can see here, an intrahepatic cholangiocarcinoma with advanced disease. I think looking at the images and taking into account the clinical picture, we can be quite confident on the diagnosis of a biliary tract cancer that is advanced, is not resectable. That is important to really explain to the patient the situation we are facing, a situation where the cancer will be treated with chemotherapy with a palliative intent. And as I mentioned previously, current standard of care is going to be chemotherapy combined with immunotherapy. As we mentioned previously, immunotherapy has changed practice because currently the combination of immunotherapy and chemotherapy is the first-line treatment options for patients with advanced gallbladder and cholangiocarcinoma. Looking at our patients, performance status 1, it would be an ideal candidate for this type of treatment. There are no contraindications for immunotherapy, good liver function, good performance status, and diagnosis of advanced biliary tract tumor. Therefore, a good candidate for cisplatin and chemotherapy, but in this case, we will combine with immunotherapy. As I mentioned previously, two options available, durvalumab or pembrolizumab. For quite a long time, immunotherapy has been developed, and as we are all aware, we are having more and more models of ways of approaching the immunotherapy paradigm for treatment of cancer. The ones that have been most developed for biliary tract tumors have been the immune checkpoint inhibitors, durvalumab and pembrolizumab. The first clinical trial that showed evidence favoring the addition of immunotherapy to chemotherapy was the TOPAZ-1 clinical trial. This was a phase 3 clinical trial randomizing patients to receive durvalumab or placebo combined with cisplatin and gemcitabine. As we see in this slide, the randomization was 1-to-1 and the primary endpoint was overall survival. Patients with gallbladder and cholangiocarcinoma in the advanced setting were recruited, all of them treatment naive. And also worth noticing that the duration of the cisplatin and gemcitabine in this clinical trial was up to 8 cycles, with subsequent maintenance of durvalumab or placebo until disease progression. In this slide, we have the primary endpoint of this study, which was overall survival. The study met its primary endpoint with a statistically significant improvement in overall survival with a hazard ratio of 0.76. It's worth noticing the separation of the curves. To me, it's very striking to see that we have 23.6% of the patients alive in the durvalumab arm at 24 months, very superior to what we see in the chemotherapy arm with 11.5% of the patients alive, almost double if we add the durvalumab. Interesting also to see in the TOPAZ clinical trial the subgroup analysis and how most of the subgroup were benefiting. Really relevant and important to check on the data that we have for the PD-L1 expression, especially because as we can see in this first plot, there is no specific role of PD-L1 as a biomarker for selection of patients. Therefore, the role of durvalumab is regardless of the PD-L1 for patients with biliary tract tumor, and in the absence of a contraindication for immunotherapy, patients seem to benefit equally from durvalumab regardless of PD-L1. In terms of progression-free survival, which was one of the secondary endpoints, the study met this endpoint as well. There was a statistically significant improvement in progression-free survival with a hazard ratio of 0.75. We also have an improvement with response rate, 26.7% in the durvalumab arm versus 18.7% in the placebo arm. Regarding toxicity, this treatment was well tolerated. We had the expected immune-related adverse event, but in general, the addition of durvalumab was not making the chemotherapy more toxic, which was one of the concerns at the time of the design of this clinical trial. Therefore, the addition of durvalumab improves overall survival, progression-free survival, response rate without making the treatment more toxic and with a good safety profile. The second clinical trial of relevance in this setting is the KEYNOTE-966 clinical trial. Very similar study design. In this case, instead of durvalumab, we are using pembrolizumab, run 1-to-1 randomization, also placebo-controlled. This clinical trial was also including cholangiocarcinoma and gallbladder patients, all of them treatment naive, therefore in the first-line setting, who had a good performance status. Primary endpoint was overall survival, very similar to the TOPAZ clinical trial. One of the main differences between these two clinical trials is the fact that in the KEYNOTE-966 clinical trial, there was the possibility of doing maintenance gemcitabine beyond 8 cycles. Remember that in the TOPAZ-1 clinical trial, the cisplatin and gemcitabine was stopped after 8 cycles and only durvalumab or placebo was maintained until progression. In the KEYNOTE-966, we have the pembrolizumab and gemcitabine as a maintenance therapy. Of course, only the gemcitabine was given as a maintenance. Cisplatin was stopped after 8 cycles. These are the baseline characteristics of the KEYNOTE-966 clinical trial. We have a predominance of intrahepatic patients, a majority had metastatic disease. Primary endpoint, overall survival, was met with a statistical significance in favor of the pembrolizumab arm. Again, we see a 24-month overall survival rate superior for the pembrolizumab, 25% versus 18% with chemotherapy only in the placebo arm. Therefore, a positive clinical trial providing us with pembrolizumab as another option of immunotherapy to be added to cisplatin and gemcitabine, and therefore changing our standard of care, which had been cisplatin and gemcitabine for many, many years. The forest plotting here is again showing a very similar benefit for all the subgroups. Again, I would like to bring to your attention the fact of the PD-L1 status not be a biomarker for selection of patients. Therefore, similar to what was happening with durvalumab, with pembrolizumab, there is no role of PD-L1 as a biomarker, and therefore all patients could be treated and benefit from pembrolizumab regardless of the PD-L1 state. These are the data for the long-term follow-up that were recently presented in ASCO 2024, and as we can see, we now have the overall survival data at 36 months, showing superiority for the pembrolizumab arm. Regarding safety, very similar to what we saw with the durvalumab, these treatments are well tolerated and they are not making the chemotherapy more toxic. Therefore, very welcome good news for biliary tract tumors. We can see how the quality of life was maintained despite the addition of pembrolizumab into the chemotherapy combination. Other immunotherapy options have also been tested, for example, the combination of atezolizumab and bevacizumab with cisplatin and gemcitabine in the IMBRAVE 1-to-1 clinical trial. In this setting, we see a trend towards benefit for the combination of atezolizumab and cisplatin, even though we did not reach a statistical significance and is still not considered as standard. Therefore, cisplatin and gemcitabine with durvalumab or pembrolizumab are now considered a standard of care in this setting. And going back into Philip's case, I do believe that this could be the treatment I will choose. And again, most importantly, regardless of the PD-L1 status, we do not need to check for PD-L1 status in biliary tract tumors to go for an immunotherapy strategy. Let's now focus on how can we manage the adverse events associated with chemoimmunotherapy regimens in biliary tract tumors. As I mentioned, these treatments are usually very well tolerated, but it's true that patients with biliary tract cancer may be more fragile than other patients with other cancers and receiving other chemotherapies. In the case of Philip, for example, we did have some form of anemia, and as we can see here, for example, hemoglobin was down to 9, something very, very common when we are using chemotherapy with cisplatin and gemcitabine. Myelosuppression is one of the main issues. I usually favor dose reduction or delaying of chemotherapy to allow recovery of this myelosuppression. But overall, the addition of durvalumab and pembrolizumab is not going to make the chemotherapy more toxic. Despite that, it's true that we must keep an eye on the immune-related adverse event, and this is something that will always appear in the presence of an immunotherapy compound being part of our treatment strategy. In this slide, we have a summary of the wide spectrum of symptoms and syndromes that we could have derived from the immune-related adverse event that we are very familiar with related to the immunotherapy in cancer. Also very familiar with the different forms of immunotherapy, for example, the PD-1 or the PD-L1 inhibitors and the CTLA-4 inhibitors having a different profile of this immune-related adverse event. As I mentioned, the data we have from both TOPAZ and the KEYNOTE clinical trial is that these immune-related adverse events may appear, but they are manageable and they are not usually a huge concern for the treatment of our patients. We do have multiple guidelines for the management of this toxicity, and one of the examples is the ESMO guidelines, which we have different recommendations depending on the grade and the type of immune-related adverse event that we are facing, and that encourage you to really look into the guidelines and apply them into your practice. As a general message for grade 1, we usually only need symptomatic and supportive therapy. If we are in a grade 2 moderate immune-related adverse event, we usually need to have a break of treatment and utilize oral steroid. And for more severe toxicity, grade 3, intravenous steroid. For grade 4, of course, intravenous steroid, and sometimes also we can never restart therapy. Going back to Philip, as expected, we didn't really have many immune-related adverse events, and apart from the immunosuppression, there were no many other toxicities. Something that is what we are seeing currently with the use of nivolumab into other clinical practice, and also with pembrolizumab. In terms of the role of immunotherapy in the second-line and third-line setting and beyond for biliary tract tumors, we do also have some data to support its use, but we must be much more careful and it's not considered so standard, with the exception of patients with NMR deficiency or MSI-H, and I will show you a few data. Let me first introduce you our second patient. She's called Christina and is a 60-year-old female who has progressed to first-line chemotherapy. She remains fit with a performance status of 1 and has confirmed biliary hepatic disease, also with pulmonary metastasis. Patient received upfront chemotherapy with cisplatin and gemcitabine, and there was quite rapid progression after 4 months of therapy. One of the options of treatment has been immunotherapy, and of course we started with immunotherapy in patients who have received prior lines of treatment. But we very quickly realized that immunotherapy alone was not as effective as it could be the combination of immunotherapy with the chemotherapy. And that's why KEYNOTE and the TOPAZ clinical trials were developed with cisplatin and gemcitabine in the first-line setting. The truth is that the activity of immunotherapy in the second or third-line setting, in the absence of combination with chemo, remains only for patients with MSI-H or MMR deficient. And outside that patient population, immunotherapy alone is not of very much benefit. The KEYNOTE 158 clinical trial included patients with cholangiocarcinoma and biliary tract tumors who had MSI-H and MMR deficiency, and patients were treated with pembrolizumab alone. And as we can see in the setting of MSI-H or MMR deficiency, pembrolizumab alone can achieve very nice responses, some of them being complete responses, even in patients who have received prior. Therefore, as of today, the role of immunotherapy in the second and third line setting is limited to the use of pembrolizumab alone for patients with MSI-H and MMR deficiency, which for patients with biliary tract tumor represent a very small proportion of patients, less than 5% of all our patients. Because of this and because of the lack of benefit from immunotherapy alone beyond first-line treatment in the absence of a chemotherapy compound, different combinations are being tested. We have, for example, the data from the NIP-005 study combining pembrolizumab with lenvatinib in patients with biliary tract cancer. With this form of combinations, we achieve better responses than with immunotherapy alone, and here, for example, we have a 10% of partial response. In this table, we have a summary of different combination strategies being tested in the second and beyond line setting for patients with advanced biliary tract cancer. And it will be really important and really encouraging for us to see this data and to see how can we also implement immunotherapy beyond the first line setting for patients with advanced cancer, beyond MSI and hormone deficiency settings. Going back to Christina, as I told you previously, there was progression to cystatin and the MSI-H after 4 months, and there was also performed a molecular profiling, and she was found to have MSI-H status. Based on this, absolutely yes, I will go for a pembrolizumab option for her. If she didn't have the MSI-H status, I would like to really look into the whole panel of the molecular profiling and see whether we will have any targetable alterations. And if there was nothing targetable, then the options of treatment we will have would be FOLFOX or non-autosomal identity and refidelity. To conclude, I think it's clear from the data that I have shown you that there is current evidence supporting the fact that immune checkpoint inhibitors have shown promising activity combined with chemotherapy in the first-line setting for patients with biliary tract tumors, and we have the data from both the TOPAZ-1 and the KEYNOTE-966 clinical trials supporting the use of durvalumab and pembrolizumab respectively, combined with cisplatin and gemcitabine for patients with advanced cancer of the biliary tract. Also important to take into account how important it is to perform molecular profiling of all our patients with biliary tract tumors so we can look into potentially targetable alterations and plan a potential precision medicine approach. Please bear in mind that with the exception of patients with MSI-H or MMR deficient tumors, pembrolizumab has shown very good activity with patients with biliary tract cancer. The use of immunotherapy in the second-line setting remains investigational, especially if you are going to do this as a monotherapy approach. Participating in clinical trials is always highly encouraged and is advancing in our understanding and providing our patients with the best care for the coming future. Thank you all for joining this peer review cases program focused on immunotherapy options for the treatment of our patients with biliary tract cancer. Please remember to download the slides and the practice aid as a resource for you, your staff, and of course your patient. I hope that you found this educational activity informative and useful for your practice. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, Peer Review Institute for Medical Education. This activity is supported by an educational grant from Merck Sharp & Dome LLC, a subsidiary of Merck & Company Incorporated. To access all materials for this activity, visit peerreview.com/EUX860.